Thank you very much for the invitation. It's my pleasure to be here today. Without much ado, I'm going to request that you allow me to share my screen.
Sure.
Okay, so my name is Dr. Gertie Anyanwoke. I'm an infectious disease specialist practicing here in Louisiana. These slides that I'm going to talk to you guys about are the slides that we put together in the Association of Nigerian Physicians in the Americas. We are about 18 of us put the slides together, different specialties, to be able to give comprehensive talks about COVID-19. Our goal as an Association of Nigerian Physicians in the America COVID-19 Task Force is to help disseminate the information about COVID-19 out there to as many people, especially of Nigerian origin and African origin and minorities, and then the general population as much as possible. So without further ado, let me hit onto it. So we see the coronavirus. The name coronavirus is like crown. So that's why this virus is called coronavirus. And of course, this is not the first coronavirus. We have others. However, it's similar in some respects to the other coronavirus, human coronaviruses that cause the common cold, like when people get catarrh. It is, however, a different virus in terms of that it is highly contagious. It spreads very rapidly from person to person. It can cause severe upper respiratory disease and lower respiratory disease like pneumonia. In many individuals, these illnesses can lead to death, like we saw especially earlier on. And even till now, last week I just lost a patient with COVID. The most common mode of COVID-19 spread is via infected nasopharyngeal and oropharyngeal droplets. So like when we cough or sneeze or talk or sing, you see how the viral particles just get out there. Now these ones are the bigger ones, so they don't go far enough. You look at the tinier particles, they go far. And that's why we tell people about 6 feet and or 2 meters. Some of these particles can actually go beyond 6 feet or 2 meters. So COVID-19 can also be spread via contaminated hands. And when we use our hands to touch our face, our mouth, our eye, we can get COVID-19 that way. Let me briefly talk a little bit about the biology of COVID-19. Now, this is the virus right here, SARS-CoV-2. And this is the entrance of the body space where it's going to infect the cell. This here is where it's going to bind. So once this virus gains entry into the human body, it then binds to this receptor called the angiotensin converting enzyme 2. We call it ACE2. The receptor here, it uses that receptor to gain access to the cell. You see this receptor, it uses it to gain access to this cell. Once the virus is in the cell, it now uses the human cell materials to reproduce several million copies of itself and spread it across the entire body. This is really how the virus propagates itself. So the clinical presentation, I believe Dr. Igietseme talked about some of the clinical presentation. The symptoms usually occur within 2 to 14 days after exposure. Some infected individuals may develop no symptoms at all. In the majority of cases, about, I would say 81% of symptoms may have symptoms or no symptoms at all. And recently the CDC reported estimatedly about 40% of the patients may have no symptoms. So think about it, about 40%, 4 out of 10 people that would get COVID-19 may have no symptoms at all. In others, about 19% may have symptoms that are severe enough to require hospitalization. And out of these, about 5% of hospitalized patients may require intensive care unit and ventilation assistance. The initial symptoms include the following symptoms, it's not limited to them. Patient can have chills, fever, cough, shortness of breath, fatigue. It can have muscle ache, headache. It can lose sense of smell or taste. Some of them can complain of sore throat, congestion or runny nose, nausea, vomiting, diarrhea. We're having people presenting with heart attack, people presenting with neurologic deficits, even sometimes stroke. Severe cases and complications, the ACE receptor, like I was talking about, their target for the COVID-19 virus is widely distributed throughout the body, particularly in the lungs. You find a lot of the ACE2 receptors there, in the blood vessels, in the heart, in the kidneys, in the brain, and in the gut. And if you look at a lot of the symptoms, they go in those organs. Complications may include pneumonia with respiratory failure. That's when we talk about the patient getting ARDS. Coagulation defects with thrombosis, that's basically blood clots. Cardiovascular collapse, you're talking about the patient's blood circulation is not working well. I know that there's not a lot of doctors here, so I'm going to try and explain whichever one I think is medical term. An acute kidney failure, people may have stroke, and there's this particular disease we call, it has like children develop rash and multiple different symptoms. We call them Kawasaki-like illness. We advise universal precautions to be practiced with all patients because you don't know who is COVID or not. So as members of the community, I would say, if you get to the hospital and the doctors are wearing masks and wearing all this stuff, don't get offended because there is no way of knowing who is positive and who is not positive. So to prevent being able to transmit from one person to the other and to give the doctor the confidence to take care of each patient without transmitting infection from one patient to the other, we require ourselves to wear protective gear. We advise that all the patients, no matter what you're coming to the hospital for, should first get an initial COVID-19 assessment, mainly temperature check. Do you have sore throat? Do you have runny nose? Do you have cough, nose, diarrhea, stuff like that. And once we do that, if there are anybody that are positive for this, say somebody had fever or somebody's having cough, we should separate them in the hospital because you don't want them to transmit it to the people that came to the hospital for something else. And when you do that, you are able to prevent the rapid spread of COVID-19. So now when people are suspected for COVID-19, we call them persons under investigation. We should place them on contact and respiratory droplet precautions. When I say respiratory droplets, talk about mask. And this depends on the area where the patient is. We usually do a swab in the nose. Sometimes you can do it in the throat. Recently, in fact, I think it was 2 days ago, on the 26th of August, the FDA approved the saliva test from the Abbott laboratories so that we can use our saliva to test for it at home or anywhere. It could be in the doctor's office. So it's going to get much more simpler. That's to help a lot in a situation where we are checking out the prevalence, or we want to be able to allow children to go to school and know that they tested negative, or people come to work, to kind of allow us to get back to normalcy or to some semblance of normalcy. Now, it is not worthy that all patients should be assessed for severity of COVID-19 disease. Patients that have pre-existing medical conditions, such as hypertension, diabetes, coronary artery disease, which is like heart attack, or somebody that has some lung disease like bronchitis or emphysema or asthma, especially if the asthma is moderate to severe. People that have immunocompromised conditions, maybe rheumatoid arthritis, and they are on some immunocompromised medications, people that are aged 60 and above, they are all patients that we should note may have ability to have severe COVID-19 disease. The turnaround time for the test itself should actually, this test takes a few hours, but by the time you transport it to the laboratory, you get it back. We're looking at 24 to 48 hours. Sometimes in the US, it is taking up to like maybe 7 days, 5 days. When I first did mine, it took about 9 days to come back. And that's not very efficient. It doesn't really help us in the way it should. I think that that's getting better, especially now that they are producing more tests that are easier in terms of not needing equipment and all that stuff. So I'm going to skip a lot of this stuff because I want to jump into medical intervention. So most cases of COVID-19 are either no symptoms or mild symptoms. And I'm talking about 81%. So 8 out of 10 patients may need only little intervention medically or no intervention at all. And what are the kind of intervention? First of all, I advise everybody, even before you get COVID-19, to build your immune system. What are the things we can do to build our immune system? The things that we can do to build our immune system the things that we can do to build our immune system include eating good nutrition, balanced diet. When I say balanced diet, I'm talking about you can get like 25% of carbohydrate, 25% of protein, maybe 10% of oil, fat, and stuff like that. And most of our diet should actually be fruits and vegetables, about 40%. That would give us a lot of the vitamins that we need, a lot of the elements that we need in our body to help our immune system. People should exercise. People should relieve stress. I know it's a lot of stressful situation right now. We should be conscious about that and do only things that will relieve our stress. If watching too much about COVID-19 and hearing too many bad news is a stressor for you, cut it out. Do other things. Talk to your friends. Talk to your family. I know we're doing social distancing. You can call them. You can text them. Read a book. I mean, I'm just giving advice. But I think that decreasing the stress level will help our immunity a lot. Other things that we can do is take multivitamin, take vitamin C, take zinc. That helps us to build our immunity. Now, if you have COVID-19 and you don't have any symptoms, you don't need to do anything else apart from what I've just said. If you have COVID-19 and you have mild symptoms, say your symptom is body ache or headache, take Tylenol. If you have cough, take cough medicine. Basically, you treat the symptom that is emanating from this virus, especially if it's a mild case. Now, let's talk about moderate to severe cases. These are the cases that can sometimes progress to fatal outcomes. Their patients dies. So we want to be, more gung-ho about this. A lot of these patients, we assess them in the hospital. We make sure that their fluid, they have enough fluids in their body and electrolytes. If not, we give it to them, especially the people that have been having diarrhea or nausea, vomiting. We do their blood work and try to determine how best to treat those patients. Now, when we say mild illness, let me define it. That means they don't have pneumonia. It means they have no shortness of breath, or they might have even shortness of breath, but there's no decrease in the oxygenation. And when we say decrease in the oxygenation, it's like we have this oxygen machine, we test the patient. If it's about 94% or more, then we feel like, okay, you don't have oxygen problem. You're oxygenating well. We do a chest x-ray, there is no pneumonia. Those are mild illness. When you have risk factors for disease progression, it will include when your oxygenation has a problem, which means less than 94% of oxygen or room air, whereby it's requiring us to give you oxygen. Then when we do chest x-ray, we'll see that the patient has pneumonia, or do CAT scan, the patient might have pneumonia on both sides of the lungs. I've talked about other risk factors like diabetes, hypertension, age, and people that are obese. If they the body mass index is above 40. And to calculate this, you need the height of the patient and the weight. Some patients may have multiple organs failing on them as a result of how sick they are. How do we manage COVID-19? I've talked about management of patients that have no symptoms at all or mild symptoms. Now let's talk about the management or treatment of patients that have moderate to severe disease. You want to give them enough fluids to correct as appropriate. You want to give them oxygen if they need oxygen. Then we found out that this COVID-19 has a lot of inflammation in the body. So sometimes it leads to blood clots. And so it depends on the patient. If this patient is a patient that you think is having blood clot, we should give therapy for blood clots. I would advise people that are already on aspirin to continue taking their aspirin. They don't have to stop. People that take ibuprofen or other NSAIDs like naproxen, they should continue taking those drugs. Also, another anti-inflammatory drugs are steroids, especially dexamethasone. Prednisone can work, but dexamethasone is about 6 times more powerful than prednisone. In moderate to severe cases, I believe that we should be able to use this steroid here. There are other things like antiviral therapy. This is where we don't have so much at this time. But however, I believe like a couple of months ago, we had remdesivir was given emergency use authorization by the United States Food and Drug Agency, FDA, for treating hospitalized patients with COVID-19 because it showed some promise. It doesn't necessarily cure the virus. It kind of decreases the virus shedding. And I think that with remdesivir and giving dexamethasone to these patients, it helps it to calm down the inflammation a lot. When you use the dexamethasone to calm the inflammation down and you use remdesivir to cut down the activity of the virus, I think you get a very good result. And I believe that the patients are not dying as much as they were dying when this first started. Now, we have used lopinavir, ritonavir before. This is the drug known as Calitra that we use in treating HIV patients. There was no benefit in the trial that was done by the Chinese. My first patient that was suspected of COVID, I gave this medication to. There was really no benefit. The issue of chloroquine and hydroxychloroquine, I have used them in the past because we didn't have anything better, and we thought, you know, the issue is theoretically in books. Way before this COVID-19, hydroxychloroquine or chloroquine should have been able to act on this virus. But it is one thing for you to say something theoretically. It's another thing for you to prove that. You can do something in the test tube and it looks like it is working. When you take it out of the test tube and you do it in animal studies, and then you now do it in humans, there's a lot of things and factors in play here. I used hydroxychloroquine. I didn't have much benefit. Even before the FDA came and stopped it, even before the Infectious Disease Society of America came and stopped it. And I was discussing with my colleagues in the hospital. We did not find much benefit. Now, having said that, there are still some trials that is approved by the CDC that are ongoing about hydroxychloroquine and chloroquine. I think we should wait for those trials to be conclusive to say for sure, it was not beneficial or it was beneficial. I'm not going to talk about the management of ICU patients because I know this is not a medical gathering. I'm just going to talk about a lot of the things that we have that are coming in. So in terms of management, we are looking at early diagnosis helping us. So if we increase the amount of testing that we do, we can find people much earlier and quarantine them much earlier. Another thing is, we talk about monoclonal antibodies. We can use them for treatment. We can use them for prevention. There is this current talk about recently talking about convalescent plasma and the whole furor about the CDC approving it. The issue is that convalescent plasma is when you take blood from somebody that got COVID-19 and you extract the convalescent plasma, meaning the antibodies that that person produced to fight COVID-19. So somebody that's already recovered from COVID-19 has produced antibody against COVID-19. You collect their blood and you try to give it to very sick people because you believe that there's neutralizing antibodies that would help that person in COVID-19. Theoretically, this is what we believe. That in medicine, we have to always prove our theory. We have to always prove the hypothesis instead of wasting time. So there are trials that were going on. I think they give about 30-something thousand patients this convalescent plasma. They gave some people the high dose. They gave some people the low dose. They did not do any placebo. And I understand why they won't do placebo because these patients are sick. They found out that the patients that had a high dose had 7.5% death rate versus 13-point-something% for the people that had low dose. So they felt like the people that had high dose was significant. However, that doesn't prove anything because we don't have any data on people that never got any dose at all.